Welcome to the Surgical Edge podcast for surgical insights, reviews, discussions, and to stay updated. Let's dive in.
Welcome back to the Deep Dive. Today, we are taking on what might just be the ultimate core skill in surgery.
The surgical abdominal examination.
Exactly. And, in an age of CT scanners on every corner, it's easy to think this skill is, fading.
It's not, though, and that's what we're here to talk about.
Our mission today is to prove the opposite. We're going to distill the essential, really high-yield principles and the critical reasoning that makes this exam, still the most powerful triage tool we have.
That's absolutely right. For anyone out there, on the wards, prepping for a case or facing an acute abdomen in the ER, this is about the why.
Not just the what.
Right. The goal is to rapidly tell the difference between something benign and something life-threatening, to localize the problem and guide those really big, high-stakes decisions.
It's the shortcut to knowing if you need to call the OR or if you have time for that CT scan.
Precisely.
Okay, so we're drilling down into the system, the key signs and the things that demand immediate action. But before we get into the clinical meat of it, we have to lay some groundwork.
And that has to start with a disclaimer.
The mandatory one.
Of course. This content is for reference only. It's a review of established principles. All of you listening must, and I mean must, adhere strictly to your local institutional guidelines and protocols when you're assessing patients.
Patient safety always comes first.
Always.
Okay, let's start at the very beginning, the foundation. You say the exam starts long before you even lay a hand on the patient.
It has to. Core principle 1 is all about safety, preparation, and what we call parallel resuscitation.
What does that mean in practice?
Well, of course you confirm identity, get consent, ensure privacy. That's basic. But the first real clinical question is this patient stable?
Right.
If they're distressed, hypotensive, crashing a long, meticulous abdominal exam is not the priority.
You resuscitate.
You resuscitate in parallel. You're stabilizing them while you're figuring out the next move, which might be the OR, not a 30-minute exam.
That's a key judgment call. But let's say we have a moment. The patient is stable enough. How does the physical setup of the exam change things?
Oh, it's everything. You need them supine, fully exposed from the xiphoid down to the pubis.
While maintaining dignity, of course.
Of course. But that exposure is critical. You can't find a subtle inguinal hernia if they're covered up. And then there are the basics of cooperation.
Warm hands.
Warm hands, a warm stethoscope, good light, and a calm manner. You put a cold hand on a tense belly, and you've just created voluntary guarding. The exam is already compromised.
And our position. Standing on the right side, is that just tradition or is there more to it?
It's standard, but the real pearl, the thing people forget, is to watch the patient's face. Constantly. A subtle grimace, a catch in their breath. That's your real-time feedback. It'll tell you where the pain is better than they can sometimes.
That sets us up perfectly for the actual structure. Core principle 2, the systematic sequence. We all learned it. Inspection, auscultation, percussion, palpation. Why is being so rigid about that order so important?
Because consistency is what prevents you from missing things. You skip a step, you might miss the one subtle clue that changes everything.
So you map it out, quadrants or the 9 regions.
You map it out and you follow the one crucial rule.
Examine the painful area last.
Always.
Let's talk nuance there. Why does auscultation have to come second before we start pushing around? Doesn't that sort of violate the pain last rule if the pain is generalized?
It's a fantastic question, and it's a necessary trade-off. The reason is purely physiological.
Go on.
If you start palpating deeply, you are going to mechanically change the bowel motility. You'll change the bowel sounds.
To create an artifact.
You create an artifact. You might miss the high-pitched tinkling of an early obstruction because you've just stimulated the bowel. So we listen before we manipulate. It's about getting clean data on bowel function.
That's a great clinical nugget. Knowing the why makes you remember the rule when you're busy. Okay, let's move on. We've done the setup, we've got the sequence. Now, the first physical steps, core principle 3 is inspection. Look from the end of the bed.
Yes. The overall survey. You're looking for posture, breathing, color. Is the patient pale, suggesting shock? Jaundiced. But honestly, their posture is maybe the highest yield diagnostic test you can do.
What suggests what? Because this is a huge fork in the road, right?
There's a massive fork. If the patient is lying dead still, just rigid, taking tiny, shallow breaths.
Peritonitis.
You have to be thinking peritonitis. They don't want to move a single muscle that stretches that inflamed peritoneum. But if they're the opposite, restless, writhing, can't get comfortable.
Colic.
Classic colicky pain. Obstruction, a kidney stone, maybe biliary colic. That single observation, still versus writhing, splits your differential diagnosis in two.
That's a phenomenal differentiator. What about closer inspection, specific signs on the abdomen itself?
Now you're looking for the history written on the skin,
Scars.
adhesions, hernias.
Exactly. And then distension, asymmetry, any visible masses. And then the rarer but critical signs, striae, spider naive for liver disease, or the big ones in trauma or pancreatitis.
Collins and Gray Turners. The bruising signs, periumbilical or on the flanks. They suggest retroperitoneal hemorrhage, a very bad sign.
And you mentioned a quick test you can do during inspection.
The cough test, just ask them to give a little cough. It raises intra-abdominal pressure. If that causes a sharp, localized pain, that's a great sign of localized peritoneal irritation.
Simple but effective. Okay, on to core principle 4, auscultation and percussion. We know why we listen first. The source is stress character over count.
Yes, absolutely. We're not counting sounds for a minute. We're listening for the pitch and the frequency.
So what's the classic sound of obstruction?
Hyperactive, high-pitched, almost tinkling sounds. That's the bowel fighting to push things through a blockage.
And the opposite?
The opposite is silence. Absent or really reduced sounds, especially with distension, points you towards a paralytic ileus, or maybe late-stage peritonitis.
And we shouldn't forget to listen for vascular sounds.
Right. Check for bruits over the aorta or renal arteries. But, and this is a big caveat, the absence of a bruit does not rule out in AAA.
Good point. After listening, we percuss. This is how we map out what's gas and what's not gas.
Precisely. Tympany is gas, dullness is fluid or a mass. It's great for spotting obstruction, but it's really most useful for diagnosing free fluid.
Ascites.
Ascites. You're looking for shifting dullness. And here's another tip. Percussion itself can be a test for peritonitis.
How so?
Percussion tenderness, just lightly tapping over an area. It can be just as valuable as rebound tenderness for identifying irritation, but it's often much better tolerated by the patient.
A gentler way to check for the same sign. I like that. Now we get to it. Palpation. Core principle 5. This is probably the highest stakes part of the whole exam.
It really is. You start gently, of course, away from the pain. But the critical distinction, the one that can decide if a patient goes to the OR, is differentiating voluntary guarding from involuntary rigidity.
This is the real art, isn't it? Differentiating the two when the patient is anxious and in pain.
It is. Voluntary guarding is just muscle tensing. The patient is bracing. It should get better if you can reassure them, distract them, get them to breathe out deeply.
And involuntary.
Involuntary rigidity is different. It's a board-like spasm. It's unrelenting. It doesn't matter what you do. It persists through the breathing cycle. It's a reflex from peritoneal irritation.
And finding that.
Finding true, generalized involuntary rigidity is a definitive sign of diffuse peritonitis. And that almost always means surgery. Urgently.
So your whole plan accelerates right there. After assessing that, we move to deep palpation. What are we hunting for?
Now we're looking for specific organs. The liver, the spleen, feeling for organomegaly, the kidneys, and critically, the aorta.
The AAA.
You're feeling for a pulsatile mass, but specifically an expansile one. An expansile pulsatile mass in an unstable patient is a ruptured AAA until proven otherwise. It's an absolute emergency.
And then the classic peritoneal signs to confirm.
Right. Rebound tenderness, pain that's worse on release, and like we said, percussion tenderness. If those are present, it's just more strong evidence for peritonitis.
To round it all out, core principle 6 is about special tests and adjuncts.
These are the targeted maneuvers. You have to know them.
Murphy's sign.
For acute cholecystitis, that inspiratory arrest, down in the right iliac fossa, you've got Rovsing's, psoas, and obturator signs for appendicitis. And then flank tenderness for kidney issues.
Now, for everyone listening, we know these steps.
Okay.
But where do people commonly fall short? What's the most common thing people skip?
The completion of the exam. This is the medico-legal danger zone.
Meaning?
The abdominal exam is not complete until you've checked all the hernia orifices. Groins, umbilicus, old scars. You have to rule out an incarcerated hernia.
And the other parts.
And absolutely the necessity of a rectal exam for GI bleeding, or a pelvic exam in a young woman with lower abdominal pain. Skipping those can lead to missing a rectal cancer or a ruptured ectopic pregnancy. It's a critical error.
Those aren't just checklist items. They're safety nets. Okay, let's pull all of this together. Significance for surgical decision-making. How does this exam actually change what we do?
Significance 1 is simple. Early identification of the acute abdomen. The exam gives you this constellation of high concern signs.
The rigidity, the tenderness.
Generalized tenderness, guarding, rigidity, rebound, plus systemic upset tachycardia, fever, hypotension. If you see that picture, you don't wait, you move. You expedite imaging or you start planning for the OR.
So you're thinking perforation, ischemia.
Something catastrophic, and if that picture isn't there but you suspect obstruction, the exam gives you that classic pattern.
The colicky pain, distension, vomiting.
And those high-pitched tinkling sounds. That pattern immediately tells you the management path. 4V fluids, NG tube, and start the surgical workup. The exam sets the trajectory.
Significance 2 is anatomical localization. How does this save us from just ordering every test under the sun?
It prevents scattergun testing. It's focused. If you have RUQ tenderness and a positive Murphy's sign, your first thought and your first test should be an ultrasound of the gallbladder.
You're not ordering a head CT.
Exactly. RAF tenderness with a positive psoas sign. You're focused on the appendix. It narrows the field for everyone, including the radiologist.
This leads to significance 3, guiding urgency, not replacing imaging. We have these amazing scans, but the exam is still the triage tool.
It absolutely is. The exam decides who needs that CT scan right now versus who can be watched. But the real power, the thing that is so crucial in surgery, is the serial examination.
Tell us more about that, because that's often the deciding factor, isn't it?
It is the single most powerful diagnostic tool we possess. Tracking change.
Okay.
The patient whose localized tenderness becomes generalized rigidity over 4 hours. That is the clearest sign of surgical decline. That clinical change often happens hours before the blood tests catch up.
And the reverse is also true.
The reverse is also true. The patient whose belly softens up with some fluids and pain relief. That strongly supports a non-operative path. A negative CT scan in the face of a rapidly deteriorating exam means you trust the exam, not the scan.
The clinical picture is king.
Always.
And finally, significance 4, the communication and medical legal value.
The exam provides a shared language. When you document clearly, soft, non-tender, bowel sounds present, the next clinician can track change accurately. It allows for safe handover. And that documentation justifies your decisions whether you operate or you wait. It's the bedrock of safe practice.
So to summarize this deep dive, it's about a rigorous, systematic approach. It's about preparation, a consistent sequence, and an acute focus on those really subtle signs that differentiate voluntary from involuntary responses.
And it's about integrating all of that with anatomy and physiology to make smart, safe decisions.
It really is the ultimate tool for triage and rational planning.
And if you connect it to the bigger picture, its enduring significance is that it works anywhere. In the most advanced trauma center or in a rural clinic with no imaging, mastering this skill ensures safe surgical practice, period. It reinforces that technology supports our clinical judgment. It doesn't replace it.
That is a powerful final thought. If you found this deep dive useful, please do us a favor and share this with at least one of your colleagues or friends. Spread the word.
And don't forget to check out our YouTube channel and other social media pages for more of these highlights.
Thanks for joining us.
Thank you for listening to the Surgical Edge podcast. Don't forget to like, share, and subscribe. Help us grow and deliver even more relevant surgical content by pressing the support button. Your contribution truly makes a difference. And don't forget to share with us your advice, feedback, and the topics you would like us to include.